All right, news done, business done, sports done. It is time for The Bench. And The Bench today is at Taifa Hall at the University of Nairobi, where our colleague Trevor Ombija is discussing the Social Health Authority, the shift from NHIF to SHIF. He has top government officials. He has an audience of very inquisitive folks. We're going to be asking the right questions, and we're going to go over to him right now, where he is going to tell us or guide us through the next phase. Trevor, over to you. Take it away.
Thank you very much, Jeff. Tonight we're having a healthy conversation, both figuratively and literally, live from the Taifa Hall at the University of Nairobi. We're talking about the migration to the Social Health Authority. What is in it for Kenyans and why is it necessary? Let me start by introducing my guest from my farthest left, Harry Kimtai, PS State Department for Medical Services at the Ministry of Health. Thank you very much for making time. Dr. Zainab Gura, Acting Deputy Director General, Ministry of Health. Thank you very much for making time. Elijah Washira, Acting CEO, Social Health Authority. Thank you very much for making time. And right next to me is Dr. Patrick Amoth, Director General, Ministry of Health. Thank you very much for making time. In the audience, we have quite a number of Kenyans who will be asking their own questions in their own way. The question from them is, what's in it for them? Do they understand what SHA is all about? Why is it necessary to move? Is there value for money? All those questions, you can also send in your questions. At Trevor Ombija, at Koinange Jeff, use the hashtag JKLIVE. Let's start off right from the CEO. And Washira, I'll start with you on this. Why are we even moving to SHA to begin with?
Thank you, Trevor. We are moving to SHA because NHIF has had very many benefits to Kenyans, and we would like to build on the benefits that NHIF has had. Number one, only a few Kenyans have benefited from NHIF because it was a contributors club. We are looking at a product that will benefit every Kenyan. That's why we are calling it universal. Number two, and I like giving this in the form of an example, in NHIF, if you took it like everyone in the informal sector was paying 500 shillings, and then the income of one is 5,000, 500 out of 5,000 shillings is 10%. If the income goes to 50,000, 500 out of 50,000 is 1%. And if you go further, you realize that the percentage becomes smaller and smaller with higher incomes. So we are looking at a more equitable arrangement where everybody is contributing the same percentage of their income. Then we have a very important point. NHIF benefits have been retained in SHA, but then enhanced. We are giving much more benefits in SHA than we were giving in NHIF. And I'll give an example of Linda Mama, where NHIF was catering for antenatal, child delivery, and postnatal clinics. In NHIF, they catered for only 2 postnatal clinics. SHA is catering for 6 postnatal clinics. And in addition to that, because NHIF only catered for the child and the mother during that time, SHA is catering for everyone in that family throughout. My final example will be Eduafia. Eduafia in NHIF was for children going to secondary schools, while now in SHA, we shall have all students, right from kindergarten to university, covered. Okay. Thank you.
Let me bring in DG Amoth on this. DG, how is the government going to guarantee availability of services at the health facilities? Because this has been the greatest challenge. You go to a health facility, they don't have the facilities there, they don't have medicine. How will you guarantee this?
Thanks, Trevor. In the development of this program, we have worked very closely with the county governments, the private sector, and the faith-based organizations who deliver healthcare services in this country. We have a commitment from the providers of services that they are going to prioritize and ensure that the necessary commodities, the necessary equipment, the necessary infrastructure is in place to be able to offer this service. It is through partnership and through partnership only that we can be able to do this. The government alone cannot be able to do it on its own. So we have assurance from the county government, we have assurance from the private sector, and we have assurance from the faith-based facilities that they're up to the challenge that is ahead of us. And working collectively, we can be able to deliver this to Kenyans. Okay.
And Dr. Zainab, so kindly explain to Kenyans, how will you know how much to contribute? And CEO has touched on it a bit. We know now that you're supposed to give in 2.75%. Based on what exactly? What if you're not in formal employment?
Thank you, Trevor. As you said, for formal employment, it's 2.75% of your gross salary. But if you are not in formal employment, we'll look at your household income. We'll do this by assessing through a tool, an income and premium assessment tool, which we also refer to as means testing tool. And this tool will be able to give us, after you enter certain parameters, to give you how much you will pay to Social Health Authority. And remember, the contributory fund is the Social Health Insurance Fund, because the other two funds, the Primary Health Care Fund and the Emergency and Chronic Fund, those ones are catered for by the government.
But how precise is this means testing? In fact, this has been the greatest conversation even across board in other departments as well, not just the Ministry of Health.
Thank you.
How accurate is it?
That is actually a very good question. And this is something that the ministry has been putting in a lot of effort in looking at the tool, having a holistic, constructive discussion around it. It is scientific, and we've had a lot of reiteration in making sure that it's actually very precise in terms of how much your income is and assessing the premiums that you will pay. But we are also not closing it up. We are saying to Kenyans that, yes, this is what you'll pay. But if you feel aggrieved, you feel like this is not what I'm supposed to pay, there is still redress mechanisms. You can apply, you can appeal, that this is not what I earn. And we are leaving that open because we know we are going to learn over the years, and we are going to make it even better and better over the years. But now we are giving that space so that you can appeal. It is taken through a process. And even after that appeal, if you're still not certified, we still have a tribunal, for you to go to. So we are having a very open space. We have done a lot of work into it. We know it is good, but we also have space for us to appeal and have that conversation with Kenyans.
Okay. PS, we know that the uptake of registration has been rather slow. In fact, before we went live, we asked some of the audience here, and a paltry 6 or 7 of them had registered. And we know that from the records, about 1.3 million or 1.6 million Kenyans have registered so far. How will you ensure that all the 50 million Kenyans register if today they're just about 1.6 million who registered?
Thank you, Trevor. I think when we started notifying Kenyans that it's now the time to register for Social Health Authority, the figures there were very low. But as we continued with sensitization and informing them about the Social Health Authority and the benefits that they are going to enjoy, we started seeing the numbers going up. Right now, as we're speaking, we are at 1.7 million Kenyans. In the morning, we had about 1.5, 1.6. But by evening, as we were checking right now before we came, we had reached 1.7. That means many Kenyans are now registering to be members of the Social Health Authority, because on the 1st of October, they will be receiving their services, insurance services, under the Social Health Authority new packages, not the NHIF. So most of them are now migrating, for those are aware. And some of them we have notified, specifically those who are members of the National Health Insurance Fund. We have notified them, we have sent them messages that come October 1st, they will be receiving their medical insurance cover under social health insurance. So automatically you're going to see the numbers going up because with the notification, with the information that they have, the numbers will go up.
Okay, so Washira, explain this to us. So what is happening on the 1st of October? Is it a deadline? And on the 2nd of October, what happens now? If I haven't registered, are you saying I can't get services? What happens?
Thank you very much, Trevor. 1st of October is not a deadline. Kenyans will continue to register as long as we're having new Kenyans being born every day. However, it is encouraged that one registers early because we do not know when disease strikes. And we wouldn't want a situation where one is sick and they cannot access service. The other good thing that is happening around registration is that we are working hand in hand with hospitals so that when you go to a hospital, you can even be assisted to register from there. So we are encouraging as many Kenyans as possible to register. What is happening on the 1st of October is that we are rolling out this new enhanced healthcare financing arrangement by Social Health Authority, SHA.
So on the 2nd of October, if I walk into a hospital, I have not registered, and I have NHIF, what happens now?
On the 1st of October, even before you get to 2nd, if you walk into a hospital and you have not registered, you will be required to register first before you can be able to access
the spot
service, yes.
Okay.
The good thing is that registration can be done straight from your phone by dialing *147 or visiting our website, www.sha.go.ke.
Okay. Before I bring in Dr. Amoth, let me bring in Dr. Zainab on this. So we're still talking about registration on the 1st of October. So you walk into a hospital, now NHIF is not working, it's SHA, but you had contributed for a full year under NHIF, and you now bring transition to SHA. What happens? Do you lose your money? And what happens at that point?
Thank you, Trevor. No one will lose their contributions. If you've paid for the full year under NHIF, the remaining amount will be transferred to SHA. After doing the means testing for unemployed, because most of the time the people who pay full year is the people who are unemployed or informal employees. So after the means testing, what you have already paid will be deducted from that so that you pay the remaining. So no one will lose their contributions.
Okay. Dr. Amoth, there's the issue of mental health in the country today. And this is a reality we are dealing with as Kenyans. Is SHA going to cover this?
Thanks, Trevor. The burden of mental health in this country is huge. On average, we lose 4 persons every day due to suicide, and 42% of Kenyans visiting any health facility have mental health signs and symptoms. Therefore, it is a huge burden of disease, and we prioritize mental health as part of the benefit package for SHA. It will span the entire spectrum from outpatient consultation, counseling, inpatient management of different mental health conditions, and also rehabilitation for drug and substance abuse.
Okay, so it's definitely covered in SHA.
It is.
Okay.
Implicitly covered.
Okay.
Explicitly, sorry,
Yeah.
Not implicitly.
Explicitly covered.
Stated.
Okay.
Yeah.
P.S. So how is SHA going to avoid the problems of fraud and corruption, something we've seen with the NHIF? It's even been reported several times.
Thank you. I think the challenge that NHIF faced was basically fraud. Kenyans were contributing for their medical insurance cover, but the few hospitals, the few individuals were actually defrauding Kenyans. As a result, they were not able, NHIF was not able to enhance their services. What we are doing currently under SHA is we have leverage on digitization. We have digitized the Social Health Authority system from end to end, meaning from registration, at the time you register, you will be verified using your biometrics, using your NRB data, because we will not have anymore the NHIF card. Or you not go to hospital to take your biometrics under the SHA system. What will be used is your own biometrics that were obtained at the time when you are getting your national ID. So our reference this time will be National Registration Bureau data that we have. So we are leveraging on that. 2, I know one of the biggest challenges that NHIF faced as a result of the audit report done by EACC was that when you look at the system, there was a lot of weakness in the NHIF electronic system. This system learned a lot from those challenges in the NHIF system, It is now improved, it is better, and it is one that will be using artificial intelligence. One, because all the patients, once you register, your data will be kept within the data registry, what you call the data registry in the National Superhighway. The doctors who are treating these patients, their registry will also be there. We'll know who are these doctors who are treating. If you are a surgeon, we know you'll be doing operations. But you're a physician, and we find that you're doing operations, sometimes we'll have to question as to why. So this system uses a lot of AI to be able to support us in detecting fraud.
Yeah.
So that's why we passed a specific law, which is called the Digital Health Agency Act, that will be able now to bring in the entire health ecosystem under one umbrella, which is called the National Superhighway, meaning whether you're in private, whether you're in public, all of them will be linked to this system.
Yeah.
So we'll be able to see you from the private side,
yeah.
we'll be able to read you from the public side, and we'll be able to detect if there is any fraud emanating from any of those facilities.
Yeah.
So we have leveraged and banked on digital system.
PS, now that you've raised this system issue, there's a conversation on that. This system is going to cost Kenyans 104 billion shillings. Is that value for money, PS?
Tavia, I want to tell you that there is value for money, because if you look at this system that you're procuring, it is not SHA that is procuring the system. It's a national system, as I've said. It brings in KEMSA for the purpose of tracing of our drugs from the point of supply to the point of dispensing. This system, again, is going to interlink the private, as I said, hospitals. All private hospitals will be linked to this system. All public hospitals will be linked to this system, meaning there is no Kenyan who will be treated without accessing their records from this main system. There is value for money in this system.
Yeah.
We've done comparison with others, this investment, because we've asked some reputable companies to do assessment for us in terms of this system. The verdict they gave us is that if we are able to implement this system, there is going to be value for money. And that's why we are urging Kenyans to register in big numbers, so that that challenge that we are facing of fraud will not be there. There is no need to buy a system that makes or has challenges and supports a lot of fraud. We have made it watertight, and that's why the investment will bring money or value for money for Kenyans.
But PS,
what happened? Let me just explain to you.
Okay.
What happens also, we looked at how then do we, if we are to procure this system that's going to make our health ecosystem to be digitized end to end, and looking at how we fund our projects, government funds projects, we looked at who are the partners who can come and support us by bringing in upfront investment so that we are able to do the digitization within the shortest time possible. We are expecting to complete this digitization within a span of 2 years, meaning the infrastructure will be in place within a span of 2 years. So we feel there is value for money in respect to the system that we put.
But how was the tendering done, PS?
I want to tell you that because of the nature of the way we wanted to procure this, we went in what we call direct procurement. And this, we got permission through the National Treasury under the Procurement and Disposal Act, Section 114A, that gives us, or gives the CS for National Treasury to grant approval if we make a request based on the complexity of the procurement of this project, because it requires that we go outside the normal tendering procedures where we do open tenders. And that's why we went into what you call direct procurement using the SPP method.
Okay. But let me bring in Elijah here before I open the floor for questions from the public here. there's a concern by human resource managers. In fact, I just got a call earlier on. They're saying when they call your team, they are not ready. They don't know what to do, because the human resource manager was telling me that they're trying to transition their people. Your team has no idea. How have you prepared your team for this transition?
Thank you very much. A lot of training has gone through. For the last 2 weeks, we have invested in training all our people on a step-by-step way of what to do with each and every process, right from patients, employers, and people handling every other aspect of the business. So, and we also went into the papers and advertised the link where they can be able to click and follow the steps that are quite easy. I would be keen to meet the employer or to interact with the employer so that we can take them through the steps that are quite easy, and we have many employers actually registering successfully.
Okay.
Yes.
Dr. Moth, are we losing Linda Mama? That's a concern that has come from the public.
Thanks, Trevor. And before I go to Linda Mama, I just want to reiterate the position taken by the peers in terms of how to reduce corruption in NHIF. One of the things that had happened previously is that NHIF used to empanel facilities and also buy services from the facilities. Under the new dispensation, that has been done away with. The single source of truth for a facility, a health facility, is the Kenya Medical Practitioners and Dentists Council. Again, that separation of powers then makes it possible for us to be able to ensure that NHIF cannot accredit the facility and also contract the same facility. So that will go a long way in also reducing the issues of fraud. Again, I want to appeal to Kenyans as to why we need to register, because even before you pay a single cent out of the 2.75, mere registration, and I urge all Kenyans to be able to register, entitles you to services under the Primary Healthcare Fund, all the entire spectrum from outpatient, inpatient, optical or eye health services, and also maternity services, and also emergency treatment. So by simply registering, doing nothing else apart from registration, automatically come on first, you will be able to access those services. And you can never be able to tell when an illness will strike. So my urge to you is to register. In terms of Linda Mama, and my friend Elijah had spoken to it earlier, actually what we have in Linda Mama is now an enhanced package. What was there has been enriched further in terms of the conditions catered for under the Social Health Authority, including the number of visits for the postnatal after delivery, capped at 6 visits, all complications, because sometimes a mother can be able to deliver normally, but after that a complication would arise. Previously, that was not catered for. Now, all complications for the mother and the newborn baby are catered for. So Linda Mama is there and is stronger than it was before.
Okay. Let me open the floor for questions. Who has the microphone? By show of hands, where's the microphone? Back there? Okay, now that you have the microphone, let's start from back there, then you pass it forward. Yes, sir. Start with your name. We'll take 3 questions at a time, answer them, then come back. Yes, go ahead. Yes, speak. The microphone is on. Just start with your name.
Okay. My name is Spencer Sachida, Chairperson for Economic Students Association at the University of Nairobi. Mr. Elijah, you said that NHIF only benefited a number of Kenyans. Then why not just open it and improve it for all? And just like CBC, the new funding model, this scheme is being rushed to Kenyans, and why does not it have a proper installation to the people and a proper way of telling them on how to do it? And why should we register when the government has all our data in the NHIF? Why don't you just transfer all the data from NHIF to SHA? And lastly, was the name NHIF the problem, or is the scandals in NHIF the problem, so that you are taking us to SHA? Thank you.
All right. Thank you very much. If you have the microphone in the middle row, whoever has the microphone in the middle row, it's your chance.
There's a
Yes.
question as well.
Yes.
My name is Fidel Castro-Liech. My question is a bit comprehensive. Number one, under SHA, the government states that they are going to provide and cater for the vulnerable. In this case, the vulnerable are Kenyans who are living below the poverty line. If you below the poverty line, that means someone who survives in urban areas on 2,400 shillings per month, and in rural areas, that is 1,600 shillings per month. Now, there are 63% of Kenyans who are living below the poverty line. If you do that math with, let's say, 50 million Kenyans, that is like 30 million of us. Now, 30 million of us, of them, that means the government will provide them 300 shillings each. That comes to 9 billion per month. In a year, that is 108 billion. So, under SHA, is there a way, or can the government stipulate and tell us that this is the money that we have provided for the vulnerable in the country? Because the government has those numbers. Why can't they tell us that under SHA, we have 108 billion that is going to cater for the vulnerable in the society? Again, when I looked at SHA, I realized that for someone who is going for a dental checkup or something, they need to pay 2,000 shillings. And someone who is going for a cancer screening needs to pay 2,500 shillings. Now, look at half of the Kenyans are living below the poverty line. Now, where are these people going to get this money? And then lastly, SHA, they say that under SHA, we need the government needs to put in place over at least a health center per population of 5,000. In this country, the places you'll drive for over 100 kilometers, but you'll not see anything that looks like a medical facility. Now, as the government put these facilities in place, because NIF was there for over 57 years, but we can see that some of these facilities were there. Can SHA tell us that these facilities have been put in place so that Kenyans can adjust swiftly and go to it? Then Kenya had enrolled something called, we have there was a card which were being given which failed. It was called Huduma number.
Yeah.
We remember the challenges with Huduma number. Now this swift shift from SHA, NIF to SHA, I feel like if it is being fast and it may fail, just like Huduma number one.
Thank you, Fidel. So we'll keep it at 2 questions each, all right, so that we allow everybody to ask, but there are already many questions, so let the panelists answer, and then we'll come back for more. You can share the questions among yourself, but the first one from Achida, why not just improve NHIF? Why the rush without sensitization? All data is available from NHIF. Why do you want us to register fresh? And the scandals. Was the NHIF the problem, or was it the name? Yes.
Thank you very much. Those are indeed very good questions. There was no problem with the name NHIF. NHIF has served Kenyans from 1966 to date, and it has done some very good work. There was a legal framework that governed what NHIF could do and could not do. Because we needed a service with a bigger scope, then we had to first come up with a fresh legal framework, and given that the two were going to run parallel for some time, the SHA Act, or the Social Health Insurance Act, was enacted on the 19th of October, 2023. They have been running parallel with NHIF. As this is happening, then we had to have 2 separate entities running together. Like I said at the beginning, SHA is an enhancement of NHIF. With SHA, we have the universal coverage. Everybody in an accident situation, registered or not, will be able to access emergency services and even treatment for the first 24 hours until they are stabilized. So to that extent, there is no problem. Let's go to data. Why not just migrate data from NHIF? Indeed, some data in NHIF is clean enough and can be migrated. But there is some other data that is not clean at all. As we were going through the data, there's a place where a man put the fingerprint, the biometrics, and the face that came up was a lady's face. There's a situation where we had one hand biometrics not agreeing with the other. So one of the greatest objectives of registering afresh is to make sure that we have very clean data for everyone. You will also realize that SHA is collecting data per household, whilst NHIF data was per individual. So indeed, the change and the need for fresh registration was very important.
Okay.
Next question.
Trevor, let
Yes.
me answer
Yes,
this
please.
question of why rush. I don't think we are rushing. In 2023, we passed the laws that enacted or brought in the Social Health Authority. After that, we had to do the regulations, and we came to the public. We asked the public, how do you want us to regulate Social Health Authority? You gave us your views, and it was validated and approved, so we now have regulations. After passing these regulations, we now notified Kenyans that the time, that was July, we informed Kenyans that they need to start registering for Social Health Authority. So Kenyans have been informed. Nobody's rushing Kenyans. Two, we also have the data from NHIF. As Wachira said, this data had to be cleaned. It took time to clean this data. And we told you that for the first time, we wanted one single source of truth, which is the NRB. Therefore, we had to run the data that was generated under NHIF and match it with the one for NRB, the National Registration Bureau, and out of the 12 million, more than 12 million people who had been registered under NHIF, only 9 million were accurate, meaning there was a difference of about 3 million that could not be traced. We can't associate with anything, because if it is not in NRB, then it is not anywhere. And that's why we are now going to migrate the 9 million Kenyans who have been verified to Social Health Authority. And we are also notifying you that from 1st of October, you will receive your benefit packages under social health insurance. So Kenyans have not been rushed. They have been informed in each and every stage. Thank you.
Okay. And DG, there was a question from Fidel in terms of the health centers availability. Have you put enough of them out there?
Thanks, Fidel, for that question. As a country, we have made big progress in terms of putting physical infrastructure in terms of health facilities. What we lack now currently is the software to be able to operationalize those physical infrastructures. We believe now is the best time for us to be able to put in additional support in terms of equipment, in terms of the necessary health workforce, rather than putting structures in which you don't have the health workforce to be able to operationalize those structures. I think if you look at the data for Kenya, it is only about 2 or 3 counties which have not met the per capita health facility number per population density. And therefore, this is the right time for us to move away from brick and mortar, put a little bit of software in terms of equipment, health workforce to be able to deliver quality services to Kenyans.
Okay. Elijah, there's also an issue of dental cover that you have to pay 2,000 shillings, and for cancer you have to pay 2,500 from Fidel. Is that the position? What is the dental cover under SHA? And your team is here, so you can refer to any of them. We can just pass the microphone.
Thank you. Thank you very much. Dental cover. Maybe I can have my director, Hazel.
Okay. And as that continues, Dr. Zainab, then let's get the microphone to the director that has been mentioned. Let's bring in Dr. Zainab here. There's the issue of vulnerable people. Do we have a specific amount of resources put aside by the government for vulnerable people? This was a question from Fidel, saying more than 63% of Kenyans are below the poverty line. So do we have resources available for that particular cadre?
Thank you, Trevor. When we were developing the Social Health Insurance Act and its regulations, that is a critical component that was actually factored in and taken care of. that we know there are Kenyans who will not be able to pay for themselves. Once Kenyans register and go through the means testing, in terms of determining the contribution to social health insurance, there are people who will, even the minimum 300 will not be able to pay. There will be verifications that will be done by the agencies that are assigned to do this, our State Department of Social Protection, the counties, and together they'll be able to verify these are actually people who are vulnerable, and that will be taken care of by the government. And these entities are actually been asked, and the ministry is following up actively, and the ministry itself is also budgeting for it. Trevor, we've been budgeting for indigents, even under NHIF. And we are continuing that even under Social Health Authority. But we are expanding it so that the indigent children who are in a school, the entities that are responsible for it also supports them. The social protection supports the people who are receiving social protection. And the Ministry of Health continues to do so. And in that way, the government is actually looking into expanding the number of people who are indigent or vulnerable that it can cover. And it's really taking this serious. Okay. Thank you.
Let me just add to that. You see, we talk of percentages of people below poverty line, but you do not have proper statistics. You do not have proper data. When you go to social protection, they have theirs. When you go to the Ministry of Health, they have theirs. All the MDS, gender, for example, they have. What we are saying for the first time, and we are saying, for the purpose of health insurance, social health insurance, we want all Kenyans to be registered. And we want to know who is a Kenyan who is not able to pay because they have been assessed and they are found to be below the poverty line, as my friend has said. Those ones are the ones that we shall keep in the database for the purpose of the government to start planning and paying for their social health insurance. With that figure, once we have everybody registered, then we shall have the correct figure whereby we will be paying and we'll be budgeting for them as a government.
Okay. Before I go to Madam Director, I hope you have the microphone now. There's a question here, PS, from John Terry. He says that PS has mentioned the 104 billion to be too expensive for direct procurement. In fact, the question is, what is the justification for direct procurement?
The justification for direct procurement is provided under the Public and Disposal Act. Sometimes when you're procuring a service that has some challenges that cannot easily be found in the market, then you apply, and once permission has been granted for direct procurement, then you go through that method.
Okay.
So that's the reason as to why the way we wanted to procure that system and the way the funding of that system required that we go direct, and we had to get approval for it.
Yeah.
Thank you.
Why not just advertise for competitive bidding?
The challenges were there in terms of when you advertise, because it required a specially permitted. And once you get a specially permitted, then you request for permission to go direct. Once you identify a partner who wants to partner with us on that, then you are allowed to go direct. For this, we had already identified some partners who had kitted our community health promoters. Knowing what you were supposed to do from the community level, we now wanted to take this to the national level, and therefore we had to be very, very careful in choosing the correct partners.
Okay. And were the resources available, the 104 billion, was that coming from government?
These resources were not available at the time when you're procuring, but we had to make a provision in the sense that we allowed within the tender documents, given that we wanted a proposal, somebody or a partner who is able to give the money upfront, to invest the money upfront, and then as we continue registering and as we continue providing service under the digital health ecosystem, we'll be able to be paying in installments. So that is the arrangement of all this.
Okay.
Invest upfront, and then we shall start paying installments as we go along.
Okay.
Yeah.
Madam Director, I think you have the microphone. You were supposed to answer the question from Fidel in terms of dental cover, 2,000, and cancer, 2,500. Yes, go ahead. Start with your name, please.
Okay, thank you, Trevor. So under the Social Health Insurance Fund, we have actually have three funds. There's the Primary Healthcare Fund, There's the Social Health Insurance Fund, and we have the Emergency, Chronic, and Critical Illness Fund. So for dental cover, Mwananchi will be able to access that under the Primary Health Care Fund.
All right. Let's take a quick break now. When we come back, I know there's still a lot of questions. It's a very short break, so don't move. Let me see by a show of hands how many of you have questions. Okay, we'll come back to you. Kindly keep it at just 2 questions so that we allow everybody else to ask their questions, all right? We're taking a quick break here. When you come back, keep your views coming at Trevor Mbija, at Koinange Jeff. Use the hashtag JKLIVE. And the question here is about SHA, the transition. What happens next, all right? We're back in just a bit.
Coming up, the SHA rollout. We are live from the University of Nairobi with a panel comprising of top ministry officials.